thing that they're talking about here is the duration of action and the half-life. And we haven't talked about that yet, but we'll come back to that. So that's all this is doing is just reiterating what we did before. Okay, so we're going to start transitioning in how to use glucocorticoids. What we've done now is we've talked about the differences in the drugs and what makes pred, and dexamethasone. Now we're going to talk about how we use them regardless of the drug. And we will differ a little bit how we use them based upon the amount of glucocorticoid effect. So everybody knows what we're doing is we're interfering with an endogenous system. And this endogenous system is associated with the secretion of aldosterone and corticosteroid from the adrenal glands. And that secretion, of course, is mediated by ACTH, which in turn is stimulated through the corticotropin releasing factor from the hypothalamus. So we have this endogenous system that we're messing with. What we do know is whenever the body secretes aldosterone or corticosteroid, so this should be corticosteroid, then what, and we're missing an S right there, so put the S right there. So what will happen is, first of all, notice that aldosterone is targeting primarily the kidney, and corticosterone, the glucocorticoid, is targeting principally the liver. And we'll come back to that again. That will be important as we try and make sense out of these drugs. But if we pay attention to these hormones, we understand that there's a negative feedback that both of these hormones bring to the table, especially the glucocorticoids. So if we have too much secretion, then the hypothalamus is told to stop secreting corticotropin releasing factor. So what we also acknowledge is this inhibition is going to happen whether or not it's endogenous or we provide it. So if we provide the glucocorticoid, we are messing with the system and we are telling the system to not secrete anymore. And that's potentially what happens with long-term administration, because if we continue to inhibit this system, then the hypothalamus is not going to release its factor, the pituitary is not going to release ACTH, and the adrenal glands are not going to grow. And so what they will do is eventually they will atrophy. So we've learned that what we need to do is try and minimally interfere with this feedback inhibition. All right, so that's the first point about this. When we look at this system, remember in dogs and in diurnal animals, the secretion, the endogenous secretion, occurs usually in the morning. Now in cats, it's probably in the evening. So one of the things that's going to tell us is if we're going to supplement the drug, we probably want to supplement it when the body's supplementing it. So it looks like the body as much as possible. So we'll try and treat in the morning. The other thing that we'll try and do is give a physiologic dose so that we minimally interfere with this system. Now, the other thing, as we back up and look at the system, remember that this system is influenced by stress. So the more stressed our animal is, the more that we are interfering with that system. Now, that doesn't really influence how we use them. It just makes us back up and look at our patient more in depth. But the bottom line is when we put all these together, we're going to try and use these drugs in a fashion that minimally impacts endogenous secretion. And I'm going to tell you there's probably not a system that is more fundamental in controlling the body than is glucocorticoids. So when you come along with your drugs, you're taking over something that is really finely controlled. And so I'm going to encourage you to be careful doing that. So let's look at how we influence, or how this influences our use of these drugs. So we're going to use a short-acting drug, ideally one that lasts shorter than 24 hours, because we want the body to be able to kick in with this endogenous secretion. We're going to use a physiologic dose that is defined as 0.25 mg per kg of a pred, whether it's prednisone or prednisolone. That is your physiologic dose. If you're supplementing because you have an animal that's deficient, that's the dose that you would be giving. If it's a diurnal animal, morning administration. As soon as we can, we're going to try and go to alternate day use. So if we use a drug that only lasts 24 hours and we use it every other day, that's going to allow this system to do its own secreting. That's going to allow the adrenal glands to continue to be stimulated, and we won't have atrophy. And then the last thing we're going to do is we're going to taper withdrawal. The longer the animal is on this drug, despite all these efforts, the more likely you are going to suppress adrenal gland activity. And the more likely these adrenal glands will be atrophied. So what we'll do is we will slowly withdraw the drug, giving the adrenal glands time to be stimulated again and kick back in, so that we don't see an iatrogenic Addison's disease. So I'm going to tell you right now, it is not at all unusual for us to cause iatrogenic Cushing's disease. I think we do it frequently. But because we've learned how to use these drugs, it's very rare for us to cause iatrogenic Addison's disease. Does that make sense? All right. So again, putting things in perspective, this is the synthetic pathway of making steroids. Over here are the sex steroids. Over here are the adrenal steroids. What I'm showing you are how we inhibit the formation of adrenal steroids if we're treating Cushing's disease, spontaneous Cushing's disease. Have you guys talked about trilostane? No, you wouldn't have, because that would be us in pharmacology. So, if you were going to treat hyperadrenocorticism, the drug of choice to treat it is trilostane. Trilostane inhibits this enzyme, 3-beta hydrogenase, I forget what it is, hydroxydehydrogenase. We're just going to call it 3-beta HSD. But look where this enzyme shows up. It shows up here, it shows up here, and it shows up here very early in the formation of steroids, whether they're sex steroids or adrenosteroids. So trilostane inhibits this enzyme which stops the synthesis of all these steroids. And it's the preferred drug for treating hyperactive adrenal glands because I'm going to call it the most natural. And that will make sense when we look at the next drug. So the drug that we've had to use in the past to treat hypertrophied adrenal glands has been mitotane. It's also called OPPD. But the way that this drug works is it actually causes adrenal necrosis. It kills the adrenal gland. And that's why it's not ideal. We would much rather use trilostane to treat hyperadrenocorticism. Now, the last drug I put in here is ketoconazole, itraconazole. What are those drugs for? Ketoconazole, itraconazole, what do we use those for? They're antifungals. Those drugs are potent inhibitors of cytochrome P450. And it turns out that they can actually shut down an adrenal gland as well because they inhibit the enzymes. It turns out, we call them drug metabolizing enzymes, but they do a lot more than just metabolize drugs, and that's demonstrated here. Our drug metabolizing enzymes are responsible for the formation of steroids. These antifungals inhibit those drug metabolizing enzymes, and so they actually will cause the adrenal gland to potentially not secrete steroids. So, these are the overall mechanisms whereby we treat hyperadrenocorticism that is spontaneous. The drug of choice is the one in blue, trilostane. And its mechanism of action is inhibiting 3-beta hydroxydehydrogenase, steroid dehydrogenase. Okay, so now let's come back to corticosteroids. So all steroids work the same way. They're different than most drugs. Most drugs that we talked about find a receptor on the cell membrane, interface with that receptor, and cause an effect. Steroids don't do that. Steroids have to get down to the nucleus because they're going to tell the nucleus what to do. And that's one of the reasons I think it's important to understand that glucocorticoids are fundamental to physiology. Is that a question?
Yes. Sorry, I'll be taking you back.
That's all right.
Why did you say that trilostane is preferred over the mitotane?
Because mitotane causes adrenal necrosis. It destroys the adrenal gland. Good question. Okay. So when we look at steroids, that means if they're going to target the nucleus and tell the DNA what to make and what to do, we've got to get that drug into the cell membrane. And so I showed you that name nucleus, and I told you that nucleus is lipophilic and it allows the drug to get through that cell membrane. Most steroids, because they are so lipid soluble, have to be carried on proteins. Otherwise, they're going to go into the tissues and they're going to park there. And so glucocorticoids are no different. When we look at them, when we give them, they'll bind to a protein in the plasma, they'll be carried to the cell membrane, and then they will pass through that cell membrane. Once they're in the cytoplasm, they're going to find another receptor. It's actually a heat shock protein, but that receptor is then what's going to take them to the nucleus. They'll penetrate that nuclear membrane, and finally, they will interface with their receptor. They're called glucocorticoid response elements, but they're basically receptors on the DNA. Now, once that happens, they take over, and they'll tell the DNA to cause the formation of a protein. That protein ultimately is going to inhibit or stimulate other proteins. So it's all about controlling the synthesis of proteins, either decreasing the synthesis of the protein or stimulating the synthesis of the protein. Now that means a couple of things when we look at these drugs. It means, first of all, there is a lag time to effect. They're going to take a little bit of time. If the mechanism of what we want that glucocorticoid to do is based upon DNA, it's going to take a while. The other thing is we're going to have a delayed effects. Once we stop the drug, it's going to continue to have an effect because it's influenced the formation of proteins. So when we talk about the half-life of glucocorticoids, we're not going to talk so much about the plasma half-life. We're going to talk about the biologic half-life. How long do their effects stick around? So it takes a while for most of these effects to occur, and they stick around for a while. Now, it's not quite as simple as that, and I know you're thinking, man, this isn't very simple, because we're going to have some other effects to talk about. We're going to have some permissive effects to talk about here in just a couple minutes. But let's back up, and based upon what we just talked about, telling the DNA what to do, first thing I'm going to tell you is all tissues in the body, save probably mature red blood cells, all of them are influenced by corticosteroids and glucocorticoids as well. There are marked differences in species, in the tissues themselves. You know, the kidneys are going to respond primarily to aldosterone. They primarily got mineralocorticoid receptors. The liver's going to respond primarily to glucocorticoids. The liver's got more glucocorticoid receptors, and that's one of the ways that tissues differ in their response. They have the different receptors. There's differences in age, and of course, there's differences in diseases. We're not going to talk about all these differences, but I want you to understand there's going to be variable responses among patients because of these differences in receptor distribution and response. And they are subject to marked regulation. Well, why do I make that point? Well, one of the things I'm going to tell you is don't use a glucocorticoid until you're ready. Let's think about the cancer patient. Many cancers are treated with glucocorticoids, but if you use a glucocorticoid before you start the cancer chemotherapeutic protocol, the animals aren't going to respond as well because the body responds to that glucocorticoid. It will downregulate receptors, it will decrease affinity, and it will make it harder for the animal to respond to that glucocorticoid. If you use a glucocorticoid and you stop it, and you get ready to start again, it may be harder for that animal to respond the second time because the body's going to respond to the presence of the drug that you give. And that's part of the reason animals may become refractory to these drugs as well. The body responds. So there may be resistance with persistent use because of these responses. Yes, ma'am?
I'm sorry, could you explain that one more time? So you're saying if you administer a glucocorticoid prior to, for example, a cancer treatment that involves another glucocorticoid, what?
So the body's going to see that glucocorticoid, it's going to put into gear decreasing receptor numbers. So when you finally start your anti-cancer chemotherapy protocol, the glucocorticoid component will still be there, but the cancer won't respond as well because it's already seen that glucocorticoid. Okay? And it turns out probably part of that has to do with MDR, the multi-drug resistant gene. So you, at least, especially for cancer, you want to wait until you start your anti-cancer therapy. Don't be tempted to use a glucocorticoid because you know it's going to make the animal feel better. And it will. There's no doubt about that. But then unfortunately, it won't work as well. Okay, so let's transition now and let's start talking about the effects of these drugs. And we'll do this relatively rapidly because you probably know most of them. So remember, we have two groups. We have the mineralocorticoids and we have the glucocorticoids. So the mineralocorticoids targeting the kidney, proximal tubule, somewhat, but mainly the distal tubule and the collecting ducts. We'll see, as a reminder, their job is to cause sodium retention. But that's not the only place they do that. They actually do it in the colon. They do it in the salivary glands. They actually do it in the small intestine, the ileum, and in the ciliary body of the eye. And that's why sometimes and maybe the CSF, that's why sometimes we'll use mineralocorticoid containing drugs to treat things like aqueous humor problems or even hydrocephalus. They've been used to decrease the CSF fluid in hydrocephalus. And as an aside, I think it's one of the reasons why animals respond so nicely to glucocorticoids when they have inflammatory bowel disease. We'll use them to treat the anti-inflammatory component, but if that drug has mineralocorticoid activity, that actually will also decrease diarrhea because of sodium retention. So the point about that slide is there are other places in the body besides the kidney where aldosterone-like effects occur. And then, of course, in the liver, we're going to have glucocorticoid as the primary target. But the reality is we're going to see many, many tissues respond to glucocorticoids. So let's look at the impact on electrolytes and water. And I already said this. Aldosterone causes sodium retention. It will cause potassium excretion. You know that. And it happens in these areas of the body. And that's mineralocorticoid. However, this is countered with an effect of glucocorticoids. Remember I told you glucocorticoids, while the liver's the main site, glucocorticoids will have effects all sorts of places, and one of them is in the distal tubules. They'll antagonize the antidiuretic effect. So that means that the animal's going to have an anti-diuretic effect. In other words, it's going to have a diuretic effect. And we see this, the polyuria, polydipsia that characterize glucocorticoids is something that's going to drive the clients crazy. You've got to warn them that this animal may start urinating more and they're going to start drinking more. So this is a glucocorticoid. And since we're talking about electrolytes and water, as we go down here, we will see that glucocorticoids are all about mobilizing calcium. They will, or getting rid of calcium, getting rid of it in the body. They're going to prevent its reabsorption, they're going to prevent its absorption in the GI tract. They're going to get it out of the bone, and they're going to promote its excretion in the kidneys. And of all the effects of glucocorticoids, this is one I don't understand. I do not understand why their job is to get rid of calcium, but they do. They don't let you absorb it, and they get it out of the body. Now that becomes important if you have hypercalcemia, life-threatening hypercalcemia. These are great drugs for treating that. In people, because of this effect, osteoporosis is a very real problem when you use these drugs long-term. And we'll visit that again when we go forward. Okay, so that's on electrolytes and water. Now we're going to come to the tough stuff. And if we're going to talk about glucocorticoids, to me, once I understood what glucocorticoids do in the body, everything made sense. So think flight or fight. Glucocorticoids are all about getting the body ready to fight or flight. That means I need glucose for the brain. I got to have lots of glucose for the brain because that's what's going to keep you going. I have to have lots of blood to the muscles, because that's what's gonna allow me to run or fight. So glucose for the brain and blood flow to the muscles. So let's think about Buster. Buster has the problems that he has because the body, the glucocorticoids, are making protein. Glucocorticoids are catabolic in all organs save the liver. They're all about making sure that there's enough glucose in the bloodstream to feed the brain. So proteins will be broken down to form glucose. Now there'll be some amines floating around, so we're going to see BUN go up because the liver's going to convert all those amines from those amino acids into BUN, or to blood urea nitrogen. But in the meantime, we're going to have lots of glucose. That's part of the reason that Buster looks the way he does. He looks fat, but in fact, if you look at his muscles, they've atrophied. If you look at his abdomen, it's pendulous, and part of the reason his abdomen is pendulous is because the muscles supporting that abdomen are gone. The reason that he has the skin disease in part is because there's not much protein to support his skin, so he has very thin skin. The reason that he has a chronic wound is because he doesn't have the protein he needs to heal. And the reason that he has a corneal ulcer is because he doesn't have the proteins he needs to heal. So that's the major reason that Buster looks the way he does. Now, in the liver, its job is to turn this all into glucose. We've got all these amino acids coming, the liver is taking them in and converting them to glucose. And it's going to put some of the glucose in the bloodstream, but in the meantime, it's going to store a lot of that glucose, and it's going to store it as glycogen. So it's building up glycogen. It's anabolic in the liver. And in fact, it will make so much glycogen that you'll see vacuoles in the liver. And in fact, we'll have a slight hepatopathy because of that. So the nice thing about this is we've got glucose stored now to continue the fight or flight, and the liver is responsible for putting that glucose in the bloodstream.